Welcome to the WellnestMamas podcast.
We are committed to leading a sustainable lifestyle and making community connections. In a world where stress and chaos seem to be the norm, finding balance and fostering a sense of true well-being is essential.
Whether you are just beginning your holistic wellness journey or are already deeply dedicated to the practice, this podcast is for you. Join the WellnestMamas as we uncover the secrets to holistic wellness and discover the power of building a healthy community that supports and uplifts one another.
Sit back, relax, and get ready to embark on a transformative journey to leading a sustainably healthy lifestyle. We're glad you're here.
Okay, so we are doing a live podcast today, so bear with us because we're just getting started, and we have Stacey Fletcher with us. Stacey is a myofunctional therapist and an incredible resource in this Northwest Arkansas community, and we just had to bring some light to her voice, you know.
It's exciting.
Welcome.
I'm Caitlin.
Steph.
I'm Stacey.
All right, Stacey, so let's get started. I really want to know why you decided to go into this little niche concept. I mean, not everybody is talking about myofunctional therapy. I know most probably haven't even heard of it. How did you get into that?
Yeah, so I have never heard of it before. I was a dental hygiene student. I got my bachelor's in that. I practiced dental hygiene. I think I was like 3 years in or so when I had my son. And then I was probably about 5 years in. I did 3 years in private practice, and then I was in public health. So I had my son. I did all the planning for, the birth I wanted and all the things I wanted that to look like. And I just assumed that you just breastfed or you didn't. Mm-hmm. Like, it was just a choice. I read nothing about breastfeeding. I was just like, I want to do that. Like, I'll just do that. So I had him. The birth went okay. There was some hiccups, and but it turned out all right. Like, he was very healthy. Like, we went home pretty soon, and but it was a very difficult journey from that point on. Like, he never fed well. He had a lip tie. He had a tongue tie. He had, like, looking back, like, some reflex things that were going on. He probably had silent reflux. Like, all these things I had no idea. Like, nobody was talking to me about that. They were just like, oh, hold him like this and just nurse him around the clock. And I'm like, this isn't working. I'm in excruciating pain. He's screaming constantly. So the first 6 months were very, very hard. We were like, I don't know, maybe a month in, and I went to, because I was just trying to find all the resources, like, what is going on with my baby? Like, he's not eating, he's not gaining weight. We were both miserable. And so I went to a La Leche League meeting, and a dear person that was there, Miss Carrie, she was like, I think your baby has a lip tie. And I was like, I don't know what you're talking about. Like, I have a degree in the mouth. I should know these things.
They're asking us to speak up a little bit on our live. They are having trouble hearing, so just a little bit louder if we can. That's all.
Sure. I might need to move the camera closer. I can do that.
Okay, we can try that.
Keep going, though.
Okay. So I was very curious about what she was talking about, because I was like, I have never heard of such things.
Yeah.
Like, the definition of ankyloglossia in our textbook was literally that, like, a picture, a definition, whatever, like a very severe case. And his didn't look like that. I had never even heard of, infants having those kind of problems. So
Sound better?
I think so.
Awesome. So I kind of jumped in and found a few web pages that were really popular, still are, like Dr. Gahiri. He was big in that world back then. Just kind of jumped into the rabbit hole of tongue ties. And I was like, well, okay, maybe she was right, and I don't have a clue what she's talking about. So I went and saw an ENT. We got his lip tie released, and because back then nobody was doing laser around here, at least not that I knew of. And I couldn't mentally drive to Wichita. That was our other option. So we did that, and it saved our breastfeeding relationship. I truly believe that's the case. It was not perfect. Like it was kind of traumatic for me, but it worked. And so we went on, and that became like a slew of rabbit holes. One led to another, and
As they tend to.
yeah, as they tend to, right? And but that jumped me into the world of non-mainstream parenting options. Like that there was another world out there I'd never heard of before, that I'd never been exposed to. So I learned about therapy in that process. I focused a lot on Thai research in the very beginning, and I was like, this is the end all be all problem. But lots more research led to that not being true. So I got into learning about myofunctional therapy, literally came across it on a Facebook page.
Wow.
Never heard of the term before, was not taught about it in school. I was like, what is this thing? It's very interesting. Learned that hygienists could study it and practice it. So I took my first class when my son was 15 months, I think. And kind of took on a life of its own. So I've done a bunch of classes since then. But yeah, that was kind of my passion of like, we struggled. I should have known about that, like it should have been part of my education, part of my knowledge base, and it wasn't. And so part of me was angry that I didn't know. And then I was like, well, okay, how could this have been better? And how can I help other people not have the same experience that we had? Because when it was all said and done, like we met our goals. I nursed him until he was 3.5, but it wasn't easy. It was roadblock after roadblock. And then, he went on to have some issues with reflex integration that we've since worked on, but things that I feel like if I had known as a parent in the beginning, that transition of our growth together would have been so much easier.
Wow.
So that's kind of how we got here.
So you've personally made an impact in my life. My middle son, Eli, he saw you for myofunctional therapy because we were looking to do like an expansion. We were looking in airway and breathing, and this is my second child. And it's like, you learn so much. I knew a lot with my first. I felt like I knew more because I understood that breastfeeding was important in shaping the palate, because it was more than just the milk. It was actually the shape of the mouth around the breast that helps form it. And I bottle fed my oldest. I breastfed him for a few months, but not mostly pumped and bottle fed him. So I knew that there was more to it and much more layers. And so whenever my middle one was born, I was like, okay, I'm going to breastfeed him. I'm going to do this. And we fought hard. And like, just like you're saying, it was a struggle. And he had a lip tie and a tongue tie that we didn't address as a baby. And we just kind of made it as far as we could. I breastfed him for about 18 months, which was great, you know, but we still didn't develop those oral, I don't know, habits.
The function.
Yeah,
Right.
the function. And I didn't know a lot about it and how important breathing through your nose was. And just, it opened up so much for me that I've seen so much benefit from actually, personal benefit as well, like noticing myself, oh my goodness, I'm breathing through my mouth, right?
Like what's causing that today?
Right. And so just like becoming more conscious of normal function has been really, really powerful for me.
Yeah, I love that, because like what we're taught, I think the older thought process is, like you said, like we know that breastfeeding can form the shape of the palate, the shape of the face, whatever, but it's a little more complicated than that, because these babies are being born with difficulties. So even if we can nurse them, and we can nurse them well, even maybe without complaint, are they nursing the way they would have nursed 100, 200, 300 years ago, or longer? Like we're not, even when you're exclusively breastfeeding a baby today, it's not without differences, right? And like from a genetic perspective, a biological, whatever we want to look at, as our basis of human function, it's different. Our world today is different than it was.
Do you think that they addressed tongue ties more often back in the day? Because I remember hearing a story, and this is just a story, I don't know if it's real or not, but apparently midwives used to like grow one of their fingernails really long and cut the tongue tie at birth, and it was just kind of like, oh, this one's going to need that, and it was just kind of like a standard.
Yeah, there's a bunch of stories to that. Like, I've seen it referenced in like some textbooks and things like that, and that was supposed to be what they did. And so, but I also feel like those, like the kind of tongue tie I think of that would have been possible is kind of a unicorn tongue tie. Like, we don't see those kinds even very often. Like, I see them every now and then, and I'm like, woo, that would have been one that, like, if that was a thing, that probably would have been a solution. And so when we're looking at them now, we kind of differentiate their appearance. So we're looking at the function, but we're looking at the appearance and trying to match the treatment with that appearance to get the best outcome. So there's some that might have been really great candidates for that kind of procedure. Those are the babies that probably go and get like a little clip in the hospital and everything was solved and they never had a bit of problem and it was a beautiful experience. But then there's a large percentage of the babies that I see specifically that happened and nothing changed, or it got worse, or they did it this way and it wasn't the right way, or whatever. So I do feel like for a group of people, that was probably an awesome solution. But then I wonder what happened with the other situations. You know, there was a time before formula when those babies had to eat. So what was happening? You know, was the baby suffering, or were they being, you know, supplemented with someone else's milk, or, you know, what was the solution back then before we had the options we have now?
Wow. So tell me, I know a lot of your philosophy is working from like a very young age is like the ideal moment. If you can get them the younger, the better. But you work with full range of individuals. What is your philosophy? Like, why do you feel it's better to start young?
Oh, great question. So a lot of that has to do with reflexes, right? So our brain and our body communicate. And so when we're born, we're kind of just a little package of reflexes, like everything we need to survive in that moment, right? So it's kind of like, I need something to tell me to eat. I need something to tell me to eliminate my waste. I need something to tell me I'm in danger, right? So we eat, we sleep, we defecate, whatever. We don't do a whole lot as infants, right? Our brain is very focused on survival mechanisms. And so those are extremely important. And when we meet those needs appropriately, not only like emotionally and contact and communication, but physically, then those reflexes change into kind of a stair-step approach. And so those babies are having these very primal reflexes, like this small little basket of reflexes. And so they're a lot easier to tap into the brain function and be able to modify that. So a lot of babies are being born with that basket of reflexes being a little disconnected. And then that impacts, or the things that impact that are going to be like, you know, position in utero, maternal movement, nutrition, sunlight, you know, all the things that we try to attain for a healthy life, right? So movement and like the maternal body, you know, stress, all those things, right? So how we came to be created, that's a factor, right? So all of these factors, and then we have the birth process, and you know, we know that can go beautifully or it can sometimes go askew. And so that process impacts. So when we have this beautifully perfect newborn, they're being born with this primal set of reflexes, but unfortunately, sometimes those aren't perfect. So when we need to modify them before 3 months, it's much easier to take that basket and rearrange it so that it's as close to perfectly sound intervention as we can get, like what we were meant to be born with, right? And then 3 months, and then 6 months, and then, you know, our developmental milestones that we watch as an infant grows, each of those things take place because those reflexes are kind of changing to the next set. They're like leveling up, if you will, right? And but they build on the previous set. And so when we're talking oral function, that is a stage where the body's like, oh, well, it works okay. You know, like you can eat. And so there's all these other important things that I have to deal with. So if the mouth isn't functioning in that perfect tier, then the body's not as concerned about it, as long as it's functioning in the basic tier, and it's going to kind of figure out the rest of the body first. So sometimes the mouth kind of gets left behind. As long as eating is working, it's not focused on good ideal function. So if that basket is left disorganized, then the next layer and the next layer and the next layer are built on that disorganization. So obviously these children can function in the world, they can survive, they can live life. But then we start to see these little inconveniences or these little nuances, these little quirks that are like, hey, is that normal? Is that not? And it all boils down to that initial basket of reflexes. So when I have a baby and we can do that, then we can set the foundation for those levels to be just a little more balanced. So then when I get a kiddo, at an older age or an adult, all of that stuff is relevant, and we can't go back to ground zero. We can't go back to that initial basket, right, and reorganize it all. We can try, and we can do some things that can really try to impact that, but we may never get that perfectly clean slate that we might have been able to get close to as an infant, that pre-3 month window. So that's kind of the thing. If we can get them early, if we can teach parents about these things before birth, if we can impact, if we could impact how we're caring for ourselves as pregnant mothers, not in a shameful way, but in like a supportive way. If we know that how we care for our bodies is going to affect, our baby's function, or knowing what those red flags are in that first week or two of life, so we can work on that basket of things early, and then they're not stuck making decisions that they didn't want to make. Sometimes we have to make hard decisions because we have to survive as parents, and those might have not been decisions that we wanted, but we have to choose the best option. And so if we can have better tools to help make those decisions easier or more informed, there's nothing wrong with a parent saying like, hey, this isn't right for me. By all means, let's change that, right? But if they didn't have all the information and they're having to make that choice out of a place of fear or panic or emergency, nobody likes to make decisions in that place. So that's kind of my philosophy of early intervention, is being able to make the biggest change, being able to give everyone the majority of the information so they can make a truly informed decision that works for their family. And then as we get bigger, we can tackle those things as they come up versus trying to go all the way back to the beginning.
I love that. It's autonomy for the individual and then autonomy for that family unit.
Yeah,
and
exactly. Because what works for my family, what I want for my family, my goals, my level of education, my goal for the future, that's not going to look the same for every family, even if we have, some similarities in core beliefs, right? But I feel like being able to have all of the information so I can make that choice, then I'm making a truly autonomous decision and not one that I feel forced into because of my circumstances.
Yeah. So, speaking of goals, I would love if you would let us know, what are your goals for your business, for what you do and how you do it for this area and beyond.
Awesome. Yeah. So as of right now, how I started to get here was I started seeing babies that were kind of like this very interesting subset of babies that just didn't respond, or people had exhausted their resources to help. And so that wasn't really my intention, but that ended up being kind of the people I got by default. And so that's been a big part of my practice, and it's still a big part, is kind of where I end up getting babies that are kind of past that initial window. Those are the majority of my referrals, is, we've seen all the people, or we've tried all the things and it hasn't helped, or it's helped a little bit, but we're not where we want to be, or, we did a tongue tie and nothing happened, a tongue tie release and nothing changed, or my symptoms are worse now, or they're different, but I don't know what to do next. And so that tends to be my biggest group of referrals. But the ones that I'm trying to reach out to and the ones that I really like are those early ones that we can collaborate with. And sometimes it doesn't mean that I'm seeing babies as their primary lactation provider, right? Or because we're not really doing myofunctional therapy on an infant, we're just taking those concepts of nasal breathing, lip closure, balance of the muscles, tongue tone, tongue function. We have a list of things we want the tongue to do, right? We're not really doing volitional therapy on a baby, right? They can't do what I'm asking them with my words, right? So, but we're taking that mindset and eliciting those things with those reflexes, right? So what I see a lot of is they're like, oh, well, you're a lactation consultant. I already have one of those, right? But I rarely do just basic lactation. We have amazing lactation consultants in Northwest Arkansas, thankfully. Like, not so much 10 years ago, we had a few. But I mean, we have enough that most people could probably seek out quality lactation care now, right? So that's not my goal. My goal is, let's see what else is there, right? Like, if I had my way, every baby, and maybe not just me, like, I'd love for all these people to be trained in this, is what is this baby doing from a reflex standpoint, from a function standpoint? Of course they're breastfeeding. Okay, they're gaining weight and they're stooling appropriately and you're not having pain, and we've ruled out all the basic 101, or maybe you've sought care for that and you've had an amazing group of people to help you, and now all that's going well. But is it going well, or is it going the way it's supposed to be going? Is that tongue, like in your case, right? Like, you made your goal of 18 months, but were we feeding in a way that we should have been feeding anthropologically, divinely, whatever we want to look at as our source? Are our muscles driving that? Is our brain driving that in a way that's actually going to make tangible change, grow our mouth in the right way, help our airway? Like, those are the things I really want to look at. And sometimes that means I can be the primary lactation caregiver, but other times I'm partnering with, speech or lactation, and I'm just a little piece of that puzzle to where we can look at baby and be like, oh, hey, this isn't quite where we want it to be. These are the things we can do to help get you closer, and that's only going to help breastfeeding be better, more functional, easier, whatever we're looking for. So if I had to lay it out in terms of definition, I love to see babies early, no matter who's on the team. I don't have to be the primary person, but I also love to do that. I love to do the lactation piece, help parents kind of figure out what works for their family, what their goals are, and then as we're growing, like, let's say baby's older and we're looking at solids, well, there's some things that we should be considering in that process, not just the things we know of, like waiting until 6 months or sitting or things like that, but we want their mouth to be ready orally. And so I see subsets of people that are like, of course, food before 1 is just for fun, but food before 1 is actually for development, right? So we don't need it nutritionally necessarily. Now, sometimes it's very advantageous for a baby that's just like borderline gaining, and we can make use of that very therapeutically. But when we're talking a 6-month-old, 7-month-old, 8-month-old, that's a window that, like, a lot of lactation consultants aren't comfortable with, and we're not doing myofunctional therapy yet. So what do we do with those babies? Maybe they had a tongue tie, maybe they had it released, maybe we didn't know about it, or maybe there's something else going on. And knowing when they're ready for solids from an oral development standpoint, knowing how we can introduce that, what cups we can use, like, to just help their next stage be better. A lot of people, like, we're still under the impression that, like, pacifier usage up until age 1 or 2 is okay because that's what we're taught. But from a developmental standpoint, there's some things we would like to change with that, right? And it's not that those are bad, but they could impact us negatively, right? So how can we make that choice for that family and decide what pieces we could modify or what pieces are working to help set them up for, most importantly, airway function, right? That's why feeding matters. That's why what sippy cup we use or how we chew our food matters, right? Like, we're growing the bones that house the airway. So then when I'm talking to older kids or, 5-year-olds or 12-year-olds or 50-year-olds, that's really what we're looking at is, how did we get here? What could we modify now? And then how do we create this environment of function to make the symptomology better? But when we're looking at a baby, we're like, man, we have this like canvas that we can just build to hopefully impact all of these things and put them on the better side of function versus the side where we're just always playing catch up. So,
Wow.
yeah.
How do you think that our modern society has contributed to this? I know a lot of it you're saying is like potentially, just the way that you were grown, this is the way you're made developmentally, but what about what we're doing? Like, I mean, I've heard rumor about, chicken nuggets, and it's like we're not chewing enough, we're not gnawing on our food like we used to.
Right?
Yeah, so do you feel like that is making an impact?
That's a huge piece, right? And so when we're thinking about our function, absolutely how we chew, right? Like if we think 500 years ago, or if we think much longer than that, right? But that's kind of a good window that we can actually grasp. Like a lot of people think they're like, oh, back in the day, and they're thinking like the 20s. And I'm like, no, we need to think like before people lived in houses as a standard of living, right? Like that's the kind of people we need to be thinking about, is when we were still living off the land, eating seasonally, being in the sun relatively 24/7, walking on the earth, like
survival living.
Yeah, like
versus
really survival living.
living.
Exactly. So, I mean, and even those of us that strive to live a life that looks something like that, like, I mean, I live in a house, like that's probably not going to change, and if you don't want to, that's great, but I probably will. I like running water. I like electricity. So, I may go and do that randomly, but I'm probably not going to live a life that I don't have those things. So, but those things take their toll, right? So when we're talking about like cellular function, like chewing is a big deal, but we have to go back and look at the human as an embryo, right? Like what was that embryo designed to expect in life, right? And from a genetic standpoint, like we were expecting that 500 year ago life, right? Like ample sun exposure, clean water, vital nutrients, right? Like just nutrients everywhere. And, being on the ground and getting that dirt in our body, and chewing from, breastfeeding, being baby worn. Like we weren't laid down, we would have been prey, right? We weren't doing tummy time. Like we weren't doing those things. We weren't put in a swing or, a swaddle. Like we were worn and carried, and we were like attached to our parent 24/7. And we co-slept, and we had 24/7 access to the breast essentially, and we were feeding in a functional manner, and then we were weaned or breastfed and given food that required excessive use of those musculatures, right? Like we were talking like jerky for a baby that could hold it, and they were chewing on chicken bones and like tubers, like hard things that they may not have been breaking down nutritionally, but they were building those muscles that are extremely important. And that pressure on bone, right? Like we grow because we walk, we are putting pressure on our bones, right? We have nutrition, we have our fat-soluble vitamins, we have our minerals, and then we have gravity, right? And so that's what causes us to grow stature. The same thing happens in the face, right? And so we need the foundation of nutrition. We need fat-soluble vitamins, we need very specific nutrients in high quantities, and then we need pressure. So we have to have all of those things together, and then we grow. And then if we don't have a tongue tie, our tongue can function, our mouth can be closed, we can breathe well. But then we add, well, why can't people nasal breathe? Okay, well, is it structure? Because they didn't chew, they had a tongue tie, nutrition, all of those things. But then allergens, like our allergies are out of control. Like all of us have just variable allergies. So, but then even in our structure, like it's a chicken and egg kind of thing, right? Like, well, my mouth didn't grow, my facial bones didn't grow, well, now my nose is smaller than it expected to be. So it's easier for me to breathe out of my mouth because, well, that hole's bigger, right? So that's kind of where we get. And it's like all of those pieces, and we can't always do all the things, right? But then we have like our epigenetic stuff that we're generations in now, right? Like I can only control my body and maybe my kids to some degree, but I can't go back and change generations of cellular processes. So I have to do what I can do. You know, like we'll never go back to 500-year-old genetics, right? But can we take a piece of our function today and change it for the better? You know, that's the question.
That is a great question.
Sorry.
Those questions, yes, that's the one that was emailed. I think that would be a really good one. Start there because she was just saying.
Absolutely.
Yes.
So a few questions from Marin. She said, well, let me kind of change these order. So she said, do you recommend tongue tie revision for newborns in most cases? And what about for adults with tongue ties? Does the revision have the same potential for positive impact in adults?
Pop that back on here.
Oh, yes.
There we go. Okay, so do I recommend a revision for infants in most cases? That's really hard to say because I don't like to look at a tongue tie. No, I used to, not anymore. I've grown a lot, I've changed a lot. I have a little bit of a different philosophy now about looking at a tongue tie and calling it a tongue tie, right? And then deciding where we go from there. So when I do a tongue tie assessment, I'm first looking at the whole body and where is the tension pattern in the body pulling on that tongue tie, or vice versa. What is that tongue tie causing in the body? What might be going on in the body that's contributing to the way this tongue is functioning, right? So our tongue is attached to a multitude of structures throughout the body via ligaments and other muscles and fascia.
Right?
And
it's
so,
like tongue to toes.
Yeah, exactly.
Kind of,
tongue
like
to toes.
yeah.
Like there's some amazing pictures out there that you can look at. And so when we're saying a tongue tie, everyone's thinking this little string under the tongue, right? So by definition, it's way more complicated than that. So that's where I've came to. And when we're looking at like, you know, those classic tongue ties and the body's working well, but the tongue's a little restricted, and it's very differentiated tissue and you can just see it clear as day. And there's symptoms.
Cool, those are the same questions.
Like those are really good to address in the right environment of approach, right? So we want to look at the fascia of the body, what's the body doing, the reflexes, the cranial base, the fascia under the tongue, how the tongue is functioning, and then like most of the time it's advantageous to address that problem, whatever we're calling it. Again, it's not just a piece of tissue, right? But to address that problem earlier than to allow the systems to get jumbled, right? And the sequences to build on that level of dysfunction. Now, does that say that we can't use compensatory factors? We can do therapeutic exercises, we can do body work, we can do a bunch of things that don't require us to surgically release that piece of tissue, right? So it's kind of like, do we do nothing or do we do surgery? That's really simplistic thinking, right? So what I prefer to do is like, what is the core belief of that family? Do they feel like the surgical approach is going to be necessary to meet their goals? And then how do I fit in to that? Like if they're really, truly, fundamentally not comfortable with that, and we may have to live in a place of compensations. And that's why those exist, right? Like we can make tangible changes. We can make the function better. Is it gonna be 100%? Maybe not. But can we get 80% where maybe we had 40% before? Hey, I'll take that if that's where you're comfortable. I would never want someone to feel like they were forced into making a decision surgically and then nothing changed, right? So we can make tangible changes with that tissue, with that function, without surgery, but sometimes surgery gets us the rest of the way, and it's ideal, you know, but it's not always 100% necessary. The earlier the better in the right context. And then what was the other part? Addressing it
for an adult.
For an adult.
And she has a little bit, this one kind of overlaps. So addressing it for an adult, and then can myofunctional therapy specifically be a standalone, or does it need to be paired with like orthodontic
Oh, great question. Okay, so can it be useful for an adult? Again, we want to look at the whole picture, right? So if I have an adult come in, we're looking like our whole functional assessment, we're looking at all of that, right? Like one thing I require before we ever even consider, before I'll write that referral of doing a release, is we have to address nasal breathing. Like if I can't breathe through my nose, well, where am I breathing from? My mouth. If I'm breathing from my mouth, where is my tongue? It's obviously not at the roof of our mouth. Like there's physically can't do two things at one time. So if I'm breathing through my mouth, my tongue is in the bottom of my mouth or somewhere that it's not supposed to be. So there's literally no point in releasing a tongue tie if that's true. So we have to address nasal breathing. We have to address lip posture. We have to address tongue tone. So when we're talking tongue tone in an adult, and to some degree in a baby, I'm looking at the same thing, but in an adult, I need them to have volitional control of all 16 muscles that are related to the tongue, right? So the tongue that looks like the tongue, that piece of tissue, is 8 muscles that can shape and move. And then the ability to move our tongue in, out, up, down, whatever, that is 16 other muscles that aren't actually in the tongue, that's attached to the tongue. And so that's just the housing, right? Our little hammock of activity. And so we have to have volitional control, appropriate tone, balance, strength, coordination of all of those muscles. I have to be able to differentiate that piece of connective tissue that we call a frenum or a tongue tie from the rest of all that tissue. There's a ton of fascia, other muscular pieces, ligaments and whatnot that have to be functioning in a way that isn't getting in the way. You know, if an adult especially can just go get a tongue tie release, there's evidence, research that says that if they have apnea and what we call a Malampati score, which is the back of the tongue, if those are high, we can make their problem worse by just clipping the frenum, by just even doing a beautiful release
Because
and the proper, exactly, because they don't have the tongue function, the muscle function that they need. So when I'm addressing an adult, I take measurements. Those are a piece of the picture. We're looking at all of the movement patterns, all of the muscle control. I have a score sheet that I use. So we're giving people like, you know, are we 25% functional to 100% functional? Where are we at on this spectrum of control in all of these areas? Can you move your tongue without recruiting other muscles of the lips or the jaw or whatever? And so that's kind of our basis is, yes, we're looking at structure. I'm doing some measurements of how far can the tongue reach, how long is the frenum, but more importantly, what is that contributing to, right? And so with that information, then we can build a plan to target those deficient muscles, and then we can go do a tongue tie release if we feel like that's advantageous at the time, right? So, I mean, I have plenty of people where we get to a point where we're like, this is where we are. We've come from here. We've made it to here. What's left, right? And sometimes to bridge that gap, a frenectomy would have to happen. Now, again, it's up to the family, right? But it's my job to tell them where that deficit is and do they want to move forward? This is what's required, or do they not? And I mean, sometimes we can only get to a certain point, and then we would have to do a frenectomy and or live in that compensatory window, right? And that's okay. And then when we're talking orthodontics, it gets a little more complicated, right? So again, structure can equal function, function can equal structure. And so why can't someone nasal breathe? Well, you know, is their nose clogged with mucus? Do they have allergies? Is it habitual? Why did they stop nasal breathing? You know, at what point in their life? What were the factors that led to that, right? But there is a lot of people that the reason they're nasal breathing is because the bony structure of their face didn't grow to its full potential. And the body's like, I can get more air out of my mouth, so that's how I'm gonna breathe. So I can teach nasal hygiene, we can teach nasal unblocking exercises, we can reduce inflammation, we can do a lot of things to make nasal breathing easier, but we may not be able to tackle nasal breathing in its whole, talking daytime and nighttime, without addressing structure. And that's at any age, right? That's a 5-year-old, that's a 50-year-old. And so if we've done all the nasal things, if we've toned the tongue and we have the housing, right? The jaw is strong enough, The tongue is strong enough. We know where the tongue's supposed to go. We can seal the tongue up. We can close the lips. We're not using any extraneous muscle. There's no tension. And we've got all the nasal hygiene on board. And we're doing all the things that we could possibly do in a therapeutic sense, but we can't get nasal breathing because of structure, or we can't get the tongue to fit in the palate because of structure. Well, again, what do? Is that structure the tongue tie? Is that structure the palate? Both of those could be a factor, and then we have to decide, are we happy with the function we've gotten? Like in Eli's case, right? Like, we've gained function, right? We did a frenectomy, right? And we've got to that point. Like, could we get further?
Yes.
Palatal growth, right? Could we make that process, like the things he worked so hard for, could we make those easier, more integrated into the brain, more subconscious, less work?
Yes.
If he had more palatal structure, right? And there's lots of different ways to get that. There's lots of different approaches to get that palatal structure. Some are more gentle, some are more aggressive, some are more effective, some are less effective, but whatever feels good to that family, right? We may need that to get that next level up of function, right? So hopefully that kind of circled back to that question.
Yeah, I think so. The next question is, how much of an impact do oral structure and function have on overall dental health, specifically cavities, tooth decay issues?
Oh, awesome. So if we look at, so I have my 4 pillars, right? I'll always go back to that: nasal breathing, lip closure, tongue posture, swallow pattern, right? So those are kind of our 4 headings that I always tackle. So with cavities, they're always multifactorial. There's never one thing contributing. From the hygiene perspective, we're taught plaque control and fluoride, right? Those are your big hitters. If you actually look at the research, neither of those things are very important to, I can't say that as a hygienist, right? That's blasphemy.
We would tell.
We're going to put it on the internet. Yeah, exactly. So everyone knows all that, sorry. But really, like, the research doesn't support that. Like, it just doesn't. Like, of course we want people to have clean teeth. We don't want them walking around with, condos of biofilm on their teeth. Like, no one wants that, right? That's kind of gross. But when you look at it from a research-based perspective, it's not the volume of plaque that someone has. It's, are they living in the ghetto, or are we talking, Manhattan Avenue? What is the makeup of that biofilm, right? So cavities exist in a matrix of many other factors. And so it's that biofilm, that colony of bacteria that lives on the teeth, that pellicle, that slime that when you wake up with, it feels fuzzy, right? So that's what we're talking about. That is a living, breathing structure of billions of bacteria, right? We brush it off, we go on about our day. It grows back, right? Every time we eat, everything we eat, whether we're mouth breathing, where our tongue sits, all of that impacts the quality of that bacteria. Who kissed you as an infant, right? What did you put in your mouth and what did it touch? Like, every single bio exposure that we receive from in utero to present day affects the makeup of that biofilm. Like, it's really intensely affected by our environment. So mouth breathing makes that dry, makes it brittle, it makes it more acidic. Acid is what causes cavities, right? So acid is our danger zone. So our saliva is less. Our saliva has 7 different factors that protect us against cavities. One of them is an acid buffer. One of them is moisture, right? So it has to be amply wet. It has to be neutral, slightly basic. If it's acidic, we're in the danger zone. Most of us eat a diet that causes our saliva to be slightly acidic. Plenty of people eat a diet that causes their saliva to be danger zone acidic, right? So, I mean, your common culprits: soda, juice, Kool-Aid, the things we think about, right? But even a healthy diet certainly has factors that make our saliva acidic. So then when we add mouth breathing on top of that, when we add a restricted tongue that can't clean all the surfaces, specifically the outside surfaces of the back teeth, or when we have a lip tie that traps that acidic now saliva, it's no longer protective saliva. Now we have a pellicle, a biofilm that is dangerous, and it's being held on the teeth constantly. We can't clean it very well. We can't remove it. and we can't get the protective mechanisms of washing it out, all of that plays a role. So when we have a tongue tie, when we have mouth breathing, and then we have like normal life that may have not been a big deal before, maybe we could use our mineralizing toothpaste and we could eat well and get our nutrition, we could get our fat soluble vitamins and our minerals. Maybe if we didn't have that tongue tie in the way, or mouth breathing, or lip tie, right? Maybe those other things would be enough. But when we count those things with the other, it's a problem.
Sorry. I think I can mute you when you cough. We're learning this. Just so, do we have another question?
Yeah, we do. Okay. I'll grab some water after I ask this. Am I on?
Yeah.
Okay. So this is from Lindsay. And let's see, what was she said, anthropologically speaking, it would seem the general trajectory of base function in infancy has been on a sharp decline in the last several decades, probably at least. How do you think this will shape the health of these generations into adulthood?
Such a good question. Amazing question. One I could spend so long talking about. So how decline first, right?
Yes, she said, yes, it would seem that the general trajectory of the base function in infancy has been in a sharp decline in the last several decades. How do you think this will help shape the health of these generations into adulthood?
Wow, that is amazing. So I 100% agree. Like, we are dealing with babies that did not have these same problems, right? Yes, we have different environmental factors, like, but that decline, I mean, those of us that work in this world, I've only been doing infant work for 7 years. Mm-hmm. And even in that span, we've noticed, like, COVID took a toll. Like, just the way we function takes a toll, right? So when we're talking, like, yes, multiple decades, right, we're seeing this impact. And how is that affecting children in school? How is that affecting adult function? 100%. Like, we know that mouth breathing, sleep disordered breathing specifically. So when we're talking mouth breathing and sleep disordered breathing, we're talking like a whole sequelae of problems, right? So let's look at that first. Is when these babies are being born with this disorganized basket of reflexes, right? And then maybe they have a tongue tie on top of it. When we're looking at that, do they become mouth breathers? You know, is their mouth open? Are they mouth breathing by 6 months? How is that affecting their brain function, their quality of sleep, right? How is that affecting their ability to interact with their environment, right? Like, in other countries, sleep disordered breathing is a required evaluation process before we diagnose a child with ADHD.
Wow.
You know, first line of defense is not medication, which can maybe be necessary or beneficial, but it's not where we go first, right? We have to rule out the biological components that are contributing to that behavioral pattern, right? Mm-hmm. So we see the same thing. Like, my son has pandas, for example, and that's something that I noticed. Like, his behaviors that we had attributed to pandas, yes, we addressed that, but until we addressed his unintegrated reflexes and until we grew his airway, those behaviors didn't change. Wow. You know, once he could sleep, once he could get the quality of sleep he required, that we all require, his brain could calm down. So would his brain have been subjected to that infection if he had been able to breathe in the first place?
It's like a chicken and the egg
situation. We don't know, right? And would his body have been able to handle that better? You know, the reflexes were a big part of that too. So we did all the things at the same time, but it's because that's what he required, mm-hmm. right? So yeah, all these kiddos that are being diagnosed with ADHD, and it's not as a pathological thing, right? Like, I mean, I have ADHD tendencies. I have things that I have to work on, but I can make myself functional, right? It's how functional are we on a spectrum of being able to achieve our activities of daily living and be a functional human being, right? Like, what is happening inside our bodies that keeps us from optimal function, right? So how we sleep at night, do we have apnea? Does our kids have upper airway resistance syndrome? Like a lot of women have upper airway resistance syndrome and they're not apneic. So no one's talking about it. No one's treating it. No one's doing anything to help them function because, oh, you don't need a CPAP, right? Well, guess what? There's a whole lot of things we can do before we ever need a CPAP.
Wow.
Before we ever want a CPAP. You know, if you got one, keep it. Do what you got to do. But there's hundreds of thousands of people that need airway support. Maybe that's just myofunctional therapy. Maybe it's myofunctional therapy and a tongue tie release. Maybe it's expansion 2. Maybe it's something else. You know, some of those people might need surgery. Some of them might need a CPAP. But until we can determine what their profile is, what their symptoms are, is their lack of breathing, their jumbled reflexes affecting their function, you know, if we can get those to baseline, then we know what's left. Wow. Then we know what we can actually treat. Do they actually need medication for neurotransmitter support? Maybe. But if they take that and all those other things are messed up anyway, how much good can it do? You know, like even if that's required, we could still be addressing these other things to make them more functional children and then adults.
It's that magic pill syndrome for our society
Yeah,
that we
there's,
like, you know, like,
one to one, like this
yeah.
thing treats this problem. And
a lot
even when that thing might be necessary, if we're not looking at the base biological function of the human being as a person, you know, maybe their life could be 20 times better even with that medication. But we're just like hoping that solves all of the problems. And that's obviously, it's never going to solve sleep disorder breathing, you know?
Right.
So if we can get them oxygenating, maybe that would be the problem. So we see that a lot is when these babies are born in this decline, as she described, then it puts them at risk for being in the trajectory of dysfunction versus function. So my job is to bump them closer to what they would have been with an organized basket. Yeah. So.
Yeah, it's like sleep apnea. They say, oh, the sleep apnea is the underlying cause for all this stuff, but it's like, what's the underlying cause for the sleep apnea? You know, because I've heard like stroke, cardiac risk, all this stuff is related to sleep apnea. And it's like, if we could prevent the person from ever growing into that, you know, that would be such an impact.
And some of these children are, like we're going through this with my son right now. We chose to, we opted out of tonsil and adenoid removal. When he was 5, that was where we were headed. And I was like, I didn't really feel comfortable with that at the time. So I was like, well, let's see what else we can do. So we opted for expansion. We chose the bone-borne option because I just wanted to get in and get it over with. I needed to make those tangible changes quickly, and I felt that was the right approach for us. We've never actually released his tongue because he has a version of Ehlers-Danlos syndrome. It's contraindicated in those children with extra stretchy tissue. It may not always be, but right now that's kind of our paradigm of approach is we don't like to release those types of tongue ties, even with therapy. So we've not actually done that, but his symptoms got drastically better, you know, and then he could think and then he could function. And so we opted out of that tonsillectomy, right? Whereas his sleep study at that time showed an AHI of 1, which certain organizations in our area feel is irrelevant. And literature says that any AHI, our apnea-hypopnea index, how many times we're not breathing at night, in a child, even a 1 is dangerous. But our major organization in this area doesn't treat it until it's a 5, which is the adult standard.
Wow.
So I'm like, how many children are in this realm of sleep disordered breathing, not apnea, but that's affecting their cognitive function, their immune system? Like, how could they be better if they could breathe?
Yeah, just breathing.
Yeah, just breathing.
Just breathing.
A basic
Foundational
right.
stuff. Right. Yes, absolutely. All right. We have, it looks like 2 more questions. Says, you mentioned retained reflexes a lot. Is that generally a common teaching that is integrated into myofunctional therapy, or is this a separate teaching that you've incorporated into your practice?
Such good questions. So it depends on how you get trained. So unfortunately, myofunctional therapy as a whole is is relatively unregulated. So there's a couple leading organizations that tend to train the majority of us. They have very different philosophies. So I've taken some training with both. I've taken some training with other professionals. Some of them don't mention reflexes at all, like at all. We're learning exercise programs. Some of them are very protocoled. Some of them are very mix match. They're very like just grab something from each column. So I've taken both of those. I've taken several different approaches. Some very protocoled, which can work well for some people. And then I've taken some that are very kind of hodgepodge, categorical programs. And so my program's kind of a blend of the two. I have groups of exercises that I do for each muscle that needs addressed. So I try to group it together. So for some people, the therapy program is going to be very similar because their problems look similar. For other people, it's going to look very, very different, or it's going to have a basis that's the same, and then we're going to do a lot of other things in each section or whatever section they need. So when someone's going to see a myofunctional therapist, unfortunately, there's no regulated training that they're going to be able to fall back on and be like, oh, you're a myofunctional therapist, so you're all going to know the same thing. That is unfortunately very untrue. And the verbiage of myofunctional therapy of someone calling themselves that is also unregulated. So someone can go take a variety of courses that may or may not be optimal and call themselves myofunctional therapist. So one day that may be different, but currently it's kind of the wild, wild west. So with the reflexes, some people who teach myofunctional therapy do touch on it. Some teach it as a basis for how they develop their program, but it is not standard. I chose to, I started my reflex courses with a group with rhythmic movements, the Rhythmic Movement Therapy International or something. So I started with them, and then I've taken a lot of training in that approach. I've taken some with oral reflexes, specifically with infants, and then I have taken a few MNRI courses. So my next phase of life, that will be a huge part of what I integrate once I have more training in that department. But yeah, so most myofunctional therapists are not going to incorporate reflexes and or even know how they tie in. So that could, and it's very important. It's not always necessary to address them in sequence with myofunctional therapy, but I do have a subset of clients that the myofunctional therapy is very, very difficult because of the unintegrated reflexes. They're kind of in the way. The brain is focusing on that, and it takes them a lot of effort to get the myofunctional work accomplished. It can take them 3 or 4 times more effort than someone who doesn't have those reflexes in the way. So that it can very well be a big deal, whereas other people, it's not a problem at all.
Wow.
Interesting, very interesting. All right, our last question is also from Lindsay. She said, most of us begin down this rabbit hole as we struggle to achieve our parenting goals and help our babies. On this path, many of us discover that as adults, we could also benefit from so much of this knowledge and practice. Where should we begin?
Right? Asking for us all.
That's a great question.
Yeah.
How do we step into this?
Where do we begin?
Yeah.
Same. Like, I didn't understand any of this. Like I said before, I got into it for my son. As we uncovered all the things with him, I was like, oh, that makes sense. I could do that too. Never knew my tongue posture was poor, that I was a chronic mouth breather. I didn't know I had all those problems until I went to my first myofunctional therapy course, and I was like, I can't do that. So I had to put myself through the program first. I do a lot of reflex work on myself, as much as you can do on yourself. So depending on how you address things in your own body, right? Like, do you need advocacy? Do you need accountability? Do you need someone showing you what to do? That's obviously a huge deal. How much time and money do you have? I mean, you can spend an exorbitant amount of money on all of this kind of stuff, right? So how much are you able to work towards, right? Like my philosophy of addressing problems is start with the most, the least invasive, right? And move forward. Like structurally speaking, like the vast majority of us could benefit from expansion and or orthodontics, right? I mean, we just can.
Even as an adult?
Even as an adult,
Okay.
yes. So there are a few orthodontists in our area that do expansion safely in adults. There's ways to do it very unsafely. There's ways to do it safely. I've seen some train wrecks, but there's also ways to do it very safe in an adult. And once you're an adult, you know, sometimes expansion's not the only option. Sometimes there's more pieces that are required. But some people can get really good changes with expansion too. And then some adults are fine without it. You know, they could benefit from it, but they may be able to function without. But that's an expensive option. It's a very invasive option. You know, obviously if it's surgery, that's invasive. So what I do with reflexes and myofunctional therapy is, you know, obviously there's a cost to it, but it's relatively easy to do. It's just time, a little bit of work, and the compliance factor, right? But there's nothing invasive that we're doing. You know, if we have to add a frenectomy in there, of course, that's a procedure that we may have to work through, still less invasive than even expansion or surgery. And then we can kind of work up to that point and decide, is this necessary? Would you like to go through this next phase of the process? I have a lot of patients that I don't see until after expansion, and that works great too. So it's really like, what are you willing to part with, right? Is that time? Is that money? Is that whatever? What's an option for your family? And where do you want to start, right? What do you feel is going to get you to that next step? There's tons of myofunctional therapy videos you can do online, but you have to kind of understand the pillars, right? You have to know what you're going for, because an exercise program is just that. We can all do exercises if we don't really know why we're doing them or what our goal is, or if we get stuck, is there someone that can guide us through, you know, that process of troubleshooting what comes next, or why can I do what they're telling me to do no matter how much I try? That's a big factor. So some of it you can source yourself. Like bowspring is a gorgeous body practice that a lot of people can work on some of their own fascial work. There certainly are like rhythmic movement videos online that some people can source. So sometimes I'm more of a facilitator where if someone doesn't have a lot of money to invest, you know, I can just give them resources and they can troubleshoot. One goal of mine is to develop some of those programs that are like more like subscription based or cheaper that you can do self-study with, you know, where I can be like, hey, try this, but then you're not having to invest that one-on-one cost, right? It's a little more attainable, I guess. And then, but it's a little more meaningful than just sourcing YouTube videos, right? So that's the thing is I think pretty much anyone alive today could benefit. It's just, do you feel like the problem we're solving is important to you, right? And how much or what resources do you have access to in order to make those changes happen?
We're so glad to be able to have you as a resource in this area. And I know that you're even expanding with your knowledge base and trying to grow so that you can access more people. Do you want to tell people about what your program you're doing?
Yeah, so it'll be on the shelf for a little while because I have to finish my doctorate. But so it's a little bit of
Just a little thing.
Yeah, just a little thing. But you know, my 5-year goal is that will be completed and I'll be able to offer those services for adults, specifically for parents. My heart is moms, right? And so that we can be our very best selves, right? Like we know what we want usually, but attaining those goals is not always easy because of our own body processes, our own reflexes, our own airways and nervous systems. And so my goal eventually is to be able to expand my offerings to target the whole person, specifically mothers, and then we can care for children. And the licensure that I will have obtained at that point will hopefully also offer more insurance coverage options, because right now myofunctional therapy, it's very hard to get it covered on insurance. Lactation I do pretty well with coverage, but for children and adults it's just really an unattainable option, and so most of it's cash based, and sometimes that's great and sometimes it's not. For someone who is required to use their insurance resources, we have a couple local options that can give some direction in myofunctional therapy, which is great. when we're looking at bigger picture and OT, you know, sometimes we have to kind of mix and match those teams to get insurance coverage. Sometimes that means I'm not the right person, right? And I can just get them to the better person that can maybe get some insurance coverage until we get to a point where maybe they want me on their team for a little piece of the puzzle. So that's my ultimate goal, though, is to offer more insurance coverage, to be able to get more people services that aren't solely out of pocket, and to be able to treat the whole person, not just babies and kiddos, but also parents.
That's awesome.
Amazing. And how can our listeners reach you?
Yeah, so
Website or pages?
I have a lot of people that reach out on Facebook. I do have a website that people can message me through. That works as well. The vitalfunctiontherapies.com. But my email, I'm happy to provide that for the group. And even my cell phone number, like I don't mind texts to set up appointments or ask questions. I try to be pretty hands-on. I schedule all my own appointments. So I have a location that I see people out of in Bentonville 1 day a week, and then I'm in Fayetteville part-time as well. So
Wonderful. We'll drop that down in the comments too.
awesome.
Thank you so much for coming on, Stacey.
Yeah, thank you for having me.